Hello dear viewers, in this video which is part 10 of continuous renal replacement therapy, I will be discussing part 4 of regional citrate anticoagulation where I will discuss complications associated with this therapy. Specifically, I will discuss acid-base imbalances. Regarding electrolyte disturbances during regional citrate anticoagulation, I will discuss it in my next video. It is important to understand details of complication since it impacts management and ensures safety efficacy of CRRT therapy. Although regional citrate anticoagulation has many advantages over systemic heparin anticoagulation, it is not a perfect anticoagulation method, and serious complications may occur if monitoring is not standardized. The main complications associated with it include acid-base balance and electrolyte disturbances. When the total provision of bicarbonate exceeds the therapy requirement, metabolic alkalosis will occur. It is a relatively common and the most common but an easily controlled complication. There are two sources of bases related to regional citrate anticoagulation. One is derived from exogenous bicarbonate supplementation and other is metabolite of citrate calcium complex entered in the systemic circulation. If without exogenous bicarbonate infusion, which comes from the replacement fluids, metabolic alkalosis still exists, this situation is called citrate overload, which imply excessive citrate calcium complex entering the systemic circulation. Citrate overload is a sign of excessive citrate administration or more frequently of low clearance in the hemofilter. The risk of metabolic alkalosis varies with the different anticoagulants containing citrate. Under the same anticoagulation strength means the amount of citrate provided remains same. 4% trisodium citrate has a stronger alkalizing effect on plasma, leading to more cases of metabolic alkalosis. Each 1 millimole of citrate provided by 4% TSC metabolizes into 3 millimole of strong ion difference, while only 2 millimole of strong ion difference are produced by ACDA. The use of different replacement fluids or dialysate may also have an impact on metabolic alkalosis. When lactate replacement solution fluid and regional citrate anticoagulation are used together, metabolic alkalosis is more likely to occur because excessive alkali produced by metabolization of lactate and citrate in the body is over the therapeutical requirement during CRRT. The common treatment strategies for metabolic alkalosis include if alkali agents like sodium bicarbonates are being used, consider reducing or discontinuing such infusions. Increase the flow rate of replacement fluid or dialysate to increase the proportion of citrate calcium complex cleared by semi-permeable membrane, and it also increases the removal of circulating bicarbonate. But if without extra bicarbonate infusion and the dose of replacement fluid or dialysate is enough, it can be considered to reduce the infusion of citrate under the premise of ensuring anticoagulation effect. Reduce the flow rate of blood to match the reduced flow rate of citrate if necessary. It should be noted that lowering blood flow rate can lead to an increase in the filtration fraction of post-dilution modes of CVVH or CVVHDF, which may increase the risk of thrombosis in the filter. If the lactate replacement fluid is used, consider changing the replacement fluid formulation. The filter should also be replaced when citrate calcium complex clearance drops due to a decrease in filter efficiency. Metabolic acidosis may occur during regional citrate anticoagulation involving two different mechanisms with different management strategies. The first important cause is citrate accumulation. Here it is important to understand the difference between citrate overload and citrate accumulation, as citrate overloads leads to metabolic alkalosis and citrate accumulation metabolic acidosis. Metabolic acidosis due to citrate accumulation occurs if a patient's tricarboxylic acid cycle, also known as Krebs cycle, is significantly inhibited, such as in the presence of severe hypoxia or hypoperfusion, leading to significant metabolic impairment of citrate calcium complex. Remember, the presence of hypoxia or hypoperfusion is in itself can lead to metabolic acidosis due to lactic acidosis. So it is important to differentiate these two entities which can coexist. The presence of metabolic acidosis due to lactic acid cannot reliably predict or detect citrate accumulation. They can only indicate that a patient is at a high risk for citrate accumulation. Citrate accumulation is mostly predicted by indirect signs. The first sign is citrate gap, defined as the difference between total and ionized calcium. The total calcium level is the total of all calcium including the ionized, protein bound and citrated calcium. With progressive systemic citrate accumulation, as it is not converted to bicarbonate in the presence of hypoxia or hypoperfusion, the increased citrate combines with more ionized calcium, which lead to an increase of citrated calcium, hence total calcium, and decrease in ionized calcium. Therefore, increased total calcium, increased citrate gap, progressive ionized hypocalcemia, or a gradually increasing requirement for calcium supplementation to normalize serum levels are the signs of citrate accumulation. A gradually increasing total calcium ionized calcium ratio is highly suggestive of progressive citrate accumulation, and a ratio equal to or more than 2.25 and rising often indicates the presence of significant citrate accumulation. The decrease in plasma bicarbonates leads to new or worsening metabolic acidosis, and this is another sign of citrate accumulation. The total calcium level should be measured at least once a day to calculate the total calcium ionized calcium ratio, or more frequently if required. The suggested treatment of this condition includes down-regulating blood flow and thus reducing citrate infusion, actively managing the patient's circulation to correct hypoxia and shock, and if the above treatments are ineffective, other anticoagulant methods should be considered. Another important reason leading to metabolic acidosis is insufficient base delivery. Citrate calcium complex has the function of alkalizing plasma when it is completely metabolized in the body, that is, it is equivalent to a net input of alkali. These alkaline load on the one hand buffer metabolic acidosis in renal injury patient, and on the other hand supplement bicarbonate lost through the filter. If the net alkali load cannot meet the total demand of these two aspects, metabolic acidosis due to insufficient citrate delivery occurs. This type of the metabolic acidosis is due to the lack of net base with normal anion gap, provided there is no other cause of metabolic acidosis present. This mechanism of metabolic acidosis is completely different than during citrate accumulation. The following treatments are recommended for this condition. Additional base supplements like sodium bicarbonate, reduce the flow rate of replacement fluid or dialysate to reduce the loss of citrate calcium complex in the effluent. Remember, by reducing the flow rate of replacement fluid or dialysate, it has the potential for an insufficient therapeutic dose. And lastly, flow rate of citrate infusion can be increased and possibly simultaneously increase the blood flow rate. So to summarize, the complications of regional citrate anticoagulations are related to amount of citrated calcium complex entering the patient's body and whether it can be adequately metabolized. Metabolic alkalosis can occur if excessive complex enters the body and is completely metabolized, while metabolic acidosis occurs when the amount of complex entering the body cannot be fully metabolized, leading to citrate accumulation or insufficient base delivery partially caused by decreased complex entering the body. The factors affected removal of complex have influence on the acid-base balance, such as semi-permeable membrane and therapeutic dose. The more complex that is removed by the filter semi-permeable membrane, the less citrate calcium complex will enter the body. At a certain blood flow rate, the clearance ratio of citrate calcium complex through the semi-permeable membrane mainly depends on the replacement fluid or dialysate flow rate, which makes the part of therapeutic dose. The higher the flow rate of replacement fluid or dialysate, the higher the citrate calcium complex clearance ratio, and the less complex remains in the patient's serum. Here I finish. Hope this video is useful to understand the nuances of regional citrate anticoagulation. If you have any questions, please write them down in comment section. See you in my next video on CRRT part 11 and regional citrate anticoagulation part 5, where I will discuss electrolyte imbalances during regional citrate anticoagulation. Till then, bye and take care.